All right, so you heard that I turned the recording on. We record these meetings for the folks who can't make it. So for those of you, and I see some people who have not been regular attendees to this group, my name is Gene Ransom. I'm the CEO of MedChi, and I'm helping the HSCRC kind of coordinate these meetings. If any of you who have not been on before, you can watch the last probably 4 or 5 meetings by simply going to the MedChi webpage under EQUIP. I think the links to the videos are also on the HSCRC page, but I'm not sure. We also have some really good educational materials up there, videos specific to specialty on how the programs work. So if any of you have physicians who are participating and they want to learn more about what they're going to be doing, it's really worth watching the specialty specific videos. Today is kind of an important meeting. I'm getting ready to turn it over to Maddie Jackson, who's going to kind of walk through, her and Tequila are going to walk through the care partner agreement. And then we're going to be going through the EQIP episode playbook. One thing looking forward that I'd like to do, and I think I mentioned in the email, our next meeting is the 3rd Friday in October. Just kind of looking ahead, we're going to begin a discussion either in October or November about what episodes we're going to ask CMMI to include next enrollment period. So what I would say for those of you in other specialties that were not included in the bundles for this enrollment year, it's a good time to start thinking about what you think makes sense. And maybe if anybody has any ideas or a lot of excitement, Tequila, Maddie, and I would love to have someone churn in a kind of an idea, one pager, or write us a note so we can kind of think about it and have a discussion about it as we come to the end of this calendar year, so we can start, kind of aligning and thinking about what we want to do. One of the exciting things about how EQUIP was set up is we do have the ability to continue to add new pieces to it. So one other really important thing, if you did not receive an email from myself or Barbara Fitzgerald from MedChi, I would really ask that you reach out. I'm going to put my email address and my phone number. I'll even put my cell phone in the contact. Please reach out to me if you got this through another mechanism, if someone forwarded to you. I want to make sure everybody's on the list. Not only do we send the meeting stuff out, occasionally we'll send out other materials. So I just don't want you to miss anything. And if you have a problem, feel free to reach out to myself or Maddie with the HSCRC or Jessica with CRISP. Or you can always use the standard email address that we have for any of the EQUIP questions, and one of us will get back to you. I just don't want anybody to feel like they're not getting it. If you're not getting something, it might be because my email is going to spam, or it might be because your computer system doesn't work well with Outlook. We tend to send Outlook invites out pretty early. So just let us know if that's an issue. We want to make sure that it is open. The other thing you might want to do is typically we meet the 3rd Friday of the month, typically. So if you haven't seen a meeting and it's getting near the end of the month, it might be worth reaching out to somebody. So having said all that, am I turning it over to Tequila or to Maddie to take over and jump into the day? Is it you, Tequila, first?
Yeah, I will start off. Good morning, everyone. We are so delighted to have you this morning on our EQIP subgroup. It's hard to believe that there are nearly 71 of you on this call. So that's a tremendous testament to the amount of interest and commitment many of you have displayed related to EQIP over the past several months and even years. And so today is really an exciting update on where things are relative to EQIP. As you all know, we just finished our enrollment period. So we're really delighted to be progressing along as scheduled in the process to get EQIP launched in 2022. So for our agenda today, we're going to talk about now that the enrollment period is over, what happens next? So many of you, either you signed yourself up or you enrolled care partners through the EAT portal. So we want to make sure you understand what's going to happen next in terms of the process to get you prepared for 2022. A big part of what will have to happen will include getting signatures on care partner arrangements. So we want to spend some time today walking through the care partner arrangement to make sure that everyone understands the content and what to expect in that agreement. Then we're going to talk about the EQIP episode playbook and really give you some insight on understanding more about the Prometheus episode definitions. And of course, we have left ample time, we think, for questions and discussions. So please do feel free to chime in as we move from one section to the next. We'll be deliberate to take pauses at the end of each section just to make sure that everyone has the opportunity to get questions answered as they come up. So with that being said, I'm going to turn it over to Maddie Jackson-Fowle to get us started for the day. Over to you, Maddie.
Great, thanks, Tequila. We can go to the next slide, Jean. So just to outline the enrollment process over the next couple of months, I know we've all kind of gotten over that past big hurdle of September 1st, which was getting all of our care partner lists submitted through EQIP. So that way we could get those over to CMS for vetting. So thank you to everyone who worked very hard to, kind of track down NPIs and names of physicians in their groups and systems and submit them into the portal. Anything that was in the portal as of September 1st, we have gone ahead and submitted that to CMS for vetting, and we'll get those results back hopefully sometime in October. Throughout the rest of this month, we really anticipate that you all will finalize your episode selection and intervention selection. So the episode selections process and intervention selection process should be ongoing right now within your EQIP entities. Whatever is in the system will be declared as final as of October 15th. That's that next box as we move along. Additionally, during September, we are allowing EQIP entities to split or combine with other entities if their care partners were included to CMS for vetting. So if a care partner was on that September 1st list, they are eligible to be in the program in a different entity, in a combined entity. And our team at CRISP can walk you through that process and your specific needs if you reach out to that equip@crisphealth.org email inbox. On October 15th, we are going to close EQIP for any additional changes. We will allow you all to see the CMS vetting results of each care partner back in EQIP. So you'll get a sense of who is eligible to participate for participation year one. Additionally, with those insights, we will tell you why certain care partners did not pass vetting with CMS, whether it was an issue with their PICOs not being up to date or other items. You'll get a sense of that. So that way for next year, you'll be able to correct those issues and ensure that those care partners can participate. We also will, on October 15th, start to distribute the care partner arrangements. So these will be arrangements specific to each EQIP entity, detailing the episodes that you would like to participate in, the intervention selections that you would like to participate in, and the care partner remission recipient, or where the payment will be sent. So those contracts will start going out on October 15th, and I'll talk a bit more about that process in a few minutes. October through December, we are really going to be in full contracting mode. We will be asking EQIP entities to follow up with their care partners to ensure that the care partners arrangements are getting signed by each individual physician and care partner. This process we have set up again in EQIP, so you'll be able to see real time each week which care partner arrangements we have received back from your care partners and who you should follow up with as an administrative proxy or lead care partner of an EQIP entity. And then finally, December 31st, or the last day of this year, we will declare anyone who has signed their care partner arrangement as enrolled. Anyone who has not signed their care partner arrangement will be removed for performance and eligible to participate for year two if they pass vetting again. But this is really the deadline up until the last minute of start of this before the performance year start to get into the program. So that's really the next couple of months, and we'll kind of chat through some more of this in detail. So for September, as I mentioned, we will be asking that you finalize your episode and intervention selection. Again, this should be by October 15th so that we can fill your care partner arrangements and get those out to each care partner in your EQIP entity. You may also split and combine if people were included in vetting to CMS. A reminder here that care partners may only be in one EQIP entity. And if you need to create a new entity, there will need to be a new lead care partner designated in EAP to create that entity. So the same process exists to set up a new EQIP entity if you are splitting yours as existed to get into this system initially. We also are finalizing a deduplication of care partners across EQIP entities. This was something that was going to be expected as we have a lot of physicians who are part of a physician group, but maybe work with a home institution more consistently or as consistently. So if a care partner did not attest to a preference for one entity or another, and neither entity kind of worked it out and claimed the care partner as theirs, we are going to be assigning any leftover care partners to the smallest volume EQIP entity. The idea here is that there are some large entities that are system-wide that maybe submitted large rosters into the program. And those that have smaller rosters and smaller volumes are probably a closer locus of relationship here. Again, though, we will take care partner preference as a sort of trump card to it all. So if a care partner reaches out to us directly and says, no, I am participating with this entity, we will consider that to be the final say. You should, once you resolve any conflicts with other administrative proxies and lead care partners, we are expecting you to update and adjust your care partner list within EAP. So please reach out to equip@crisphealth.org if you're having issues or questions with this. But we would like for EQIP entities to be updating their lists within EAP themselves when these resolves are found. Next slide. I think there's a question from Luke, and it says, how do we quote unquote claim someone so they do not default to a smaller practice? That's a great question. It's usually just via email. So if you send us an email saying we've confirmed that these care partners are going to participate with us in this EQIP entity, and also sometimes CCing the other administrative proxies and lead care partners will really expedite that process so we don't have to go back and check. But essentially just send us a note that these care partners will be participating with you. Okay. So on to the fun stuff, the contracts are what we're calling care partner arrangements. These are required per the state and the University of Maryland Medical Center's agreement with CMS. We may not distribute any incentive payments to an individual or entity other than a care partner with whom the hospital, in this case UMMC, has not executed a fully executed written care partner arrangement. We are going to standardize this arrangement throughout the state, besides those three fields that I mentioned, which are the intervention selections, the episode selections, and where the payments will be made. And we will require this to be signed by each care partner in EQIP prior to participating in the participation year. So the way that this will work at a high level process is that all care partners who pass vetting and are not removed from the care partner dashboard in EAP, so essentially anyone left on your list who passed vetting, this says October 8th, apologies, it should say October 15th, will have a care partner arrangement generated for them to digitally sign. So everyone will get their own individual care partner arrangement who is left on your EAP rosters as of October 15th. Care partners will have the opportunity to sign this arrangement through December 31st, 2021. If they fail to sign prior to the start of the performance year, we will remove the care partners from the EQIP entity, and they will not be certified to CMS as participating in an AAPM. So that first step of getting people in on the 9-1 list is to basically get people vetted and checked. And then we submit another list that certifies who actually is participating in the payment model for the performance year. And so that list, we will remove anyone who has not fully enrolled into the program. All of this timeline is dependent on CMS processes and when they return results. We are not the only program in the country going through vetting for different care partners and participants in a program. So sometimes there can be lags with that. However, we will communicate any delays or changes back through the lead care partners and administrative proxies through that EQIP at Crisp Health inbox. So that's the high level kind of process over the next or couple of months. And now I'm going to go through some selected sections and just kind of chat through their purpose and any considerations for your entity as you read through the arrangements. But before I continue on, are there questions on the process or how this will work?
Maddie, this is Nikki McCann with Hopkins. You've said this probably 4 times, but just want to confirm. October 15th is the deadline by which we have to finalize our entities and our episodes.
Yes, correct.
Okay. Thank you.
Yep.
And Maddie, did you say that they're going to sign these electronically? So they're going to be sent to those email addresses that they've been enrolled with, correct?
Yes, correct. So the email addresses provided within the care partner dashboards are where the contracts will be sent. So again, during the month of September, this is a good time to administratively clean up any contacts that you think might have a better source and kind of make sure that those lists are as clean as possible. So that way contracting goes smoothly.
Got it. Thank you.
And it looks like there's a question in the chat that I will try to pull up.
While you're reading that, I've had several practices reach out to MedChi and express concern, particularly some of the larger ones, about having everyone sign. The point being, in the Maryland Primary Care Program, for example, the entity can sign for the practices, or if you're in an IPA, you can sign a contract with an insurer for all the physicians in the group. Is there any possibility we can push back to CMMI and get a little flexibility on that, especially for physicians who are set up in a way where maybe they're in a mid-sized private group and they're very used to the managing physician signing into one of these agreements? Was that a hard ask, or can we go back and ask them if they could reconsider or give us some flexibility on that change?
Yeah, so unfortunately, this is a hard line because it's a structure built already within CRP. Additionally, because we've added in so much flexibility as to how an EQIP entity can be formed, we have no other reliable way of linking providers back legally to the entity that they are participating with. So we do need attestation from each individual care partner saying, yes, I would like to participate in this EQIP entity for purposes of measurement, but then also for that AAPM status. So this is a really important step. We haven't required care partners to sign up or individually kind of interact with the program in any other way. So we're hoping a digital signature that, you guys can kind of see who has signed, follow up with them directly. We will only be reaching out once. We will send the contracts essentially, and then let EQIP entities manage that process on their back end. So we're really trying, I understand the aggregation and the administrative needs of, signing a large book of care partner arrangements. But unfortunately, this is the final step at which we could attest that care partners were in the program with certain entities. And we've gotten the benefit of the flexibility of being able to create these EQIP entities. We didn't have to tie this back to TINs or home institutions, et cetera. But as a consequence, we really need to have that individual attestation, unfortunately. But we will work with people. If your EQIP entity thinks that there is a better process, please reach out to us. We are happy to think through the operations of getting these signed in bulk. So please reach out to us if you're having individual kind of concerns about this throughout the program. And then the question I'm seeing here is that when splitting one entity into two, does the attributed clinical episode threshold remain at 50 for each entity? Yes, that is a good question and a good thing to note here. If your entity was eligible via volume, it must, when you split into two, you must be eligible via volume for 2 of them, right? So you need to make sure that there are enough episodes of the care partners that you are splitting out into a new entity to ensure that they're meeting that 11 in 1 episode category threshold test and 50 total across all episodes of participation threshold test. So great question. Thanks for mentioning that. Okay, So jumping into some selected sections of the care partner arrangement, it will have an introduction and overview section. This will outline the purpose of EQIP and its legal structure under the care redesign program. It will reference back the larger overarching agreements that UMMC has with CMS and that the state has with CMS to allow for the care redesign program. It will also include your EQIP entity's name and clinical episode categories for participation. In terms of eligibility, there will be a section on care partner eligibility, which will note the federal statutes that have the care partner requirements at the CMS level. Just as a reference, we've set this program up to ensure that anyone, oh, can we go back? Sorry. We've set this program up to ensure that anyone who we recruited and enrolled into the program will meet these requirements per CMS. Additionally, it will have a section saying that you are attesting that you utilize certified electronic health technology and CRISP, and also outline other standards for enrollment and participation as a care partner. It will also outline the CRP entity responsibilities, which is the University of Maryland Medical Center. It will, make sure that care partners are aware that this is limited to administration only, and they will not be allowed access to proprietary data from care partners. And there was no other contractual agreement with UMMC required as a contingency of this program. So essentially, as we've discussed previously, the CRP entity or UMMC is an administrator only of EQIP, and the rest of the policy and management is done at the state level. It will outline how EQIP incentive payments are distributed, which will include where your payment remission recipient is, so that the name and address of where you would like that check physically sent should incentives be earned. And then also what your intervention selections are to ensure that you're performing an activity that will qualify you to receive an incentive payment. Again, that's just in the 3 broad categories per episode of clinical care redesign, patient and caregiver engagement, and efficiency improvements. It will also outline the distribution of payments, and it will reference back to the EQIP methodology outlined in the user guide. So direct methodology of incentive payments will not be included in this care partner arrangement. We figured we didn't want to include a 20-page document for providers to sign, but it will reference back to that larger user guide that outlines the policy for year 1. Additionally, we'll note that there is a 25% stop gain, 25% of Part B services total in excess of EQIP payments. There's a section on DIS savings accountability, which we've discussed previously, but essentially care partners will note that the EQIP entity will have to offset their DIS savings year over year. And an EQIP entity can be removed for 2 consecutive years of DIS savings. So this is just a note back to providers that this is a contingency of the program. Additionally, we'll note the quality accountability that's in the program, which is probation for poor performance under the 20th percentile benchmark in the state, and removal for, again, 2 consecutive years on probation. So 2 consecutive years below the 20th percentile benchmark in quality performance for the EQIP entity. And I see there's a question here. Is the 20th percentile benchmark referring to episode cost or quality? So these are on the quality metrics. We will be publishing quality benchmarks shortly, hopefully within the next week. That'll essentially say what the 20th percentile rate is for each of the 3 quality metrics that we've chosen in the program. So essentially it will be a percentage that we are going to expect of your EQIP episodes that are having that quality metric attached back to it. So the 20th percentile, it's not 20% of your episodes. It's going to be lower based off of a statewide benchmark, but essentially that's the threshold that you need to meet to ensure that you are not on probation. And again, this is based on statewide experience, not EQIP participants. So we are anticipating that with focus of the EQIP program, EQIP participants should have very little problem reaching that 20th percentile in the performance year. Does that help answer your question, Daniel? Thank you. Okay, and then the last piece is on care partner integrity, just noting to care partners that there will be no change in their discretion as a provider. Being a physician to a Medicare beneficiary matters most first. And then care partners will provide direction to their care team and patients. This program is not intended to control or usurp the actions of a practice. Next section. So this is a section that we haven't chatted about previously, so we wanted to really outline it here. Each care partner will, in their care partner arrangement, will be noted of the patient rights that are under the Care Redesign program, which is essentially that Medicare beneficiaries will have the right to medically necessary services made available by the care partners. Medicare beneficiaries can still appeal claims and determinations in accordance with federal statute and laws already in place. Care partners cannot avoid treating at-risk beneficiaries to target certain beneficiaries to be in the program that could compromise both the integrity of our programs with CMS, but also compromise the safety of Medicare beneficiaries. So by signing this arrangement, you essentially say we will not cherry pick our patients, which we do not anticipate physicians are doing in the state, but it's good to note that this is something that CMS will be specifically monitoring. And then care partners cannot include interventions that discourage medically necessary services in the most appropriate setting. So again, your discretion as a care partner is what matters first and foremost. And there should not be any sort of more perverse outcomes of this program in terms of discouraging medically necessary services or denying different care to different beneficiaries. So I think, oh, and here's a question here that I'll try to get to things as we're going through the section. But this question is mentioning that the BMI quality measure is not currently reported by our hospitalist medicine group because it's not under MIPS. How will it impact participation? Good question as well. So as a caveat on all of those quality measures that I mentioned, you do not have to be reporting them to MIPS or via any other structure to CMS. We actually will be able to measure them at the state level off of claims. And that's detailed in our user guide, which is available on the HSCRC website. But essentially, we will be tracking claims codes for these measures, and we will not be requiring any submission from EQIP entities or care partners for us to be able to measure those things. Again, there's another section on beneficiary choice and notice. So again, care partners cannot obstruct the choice of Maryland Medicare beneficiaries to obtain health services from providers outside of our participating hospital, UMMC, or its care partners. You essentially can't say you must go to this doctor because they are part of EQIP with me and I would like to earn an incentive payment. That would be precluded under the program. Medicare beneficiaries receiving care from the EQIP care partner should be given notice that their care partner is an EQIP entity and medical staff are participating in EQIP. EQIP does not allow beneficiaries to opt out of the payment methodology. We will not be collecting these notices that you give out to beneficiaries, but we may request them as the state or for verification and compliance purposes with CMS. This notice can be done in a number of different ways. It can be done in pre-treatment paperwork. You can post notice within your clinic, really whatever way that the beneficiaries you are treating will receive information that you are a part of this program. You have your discretion there. We can request to see how you have done that, but we do need to give beneficiaries notice that you are participating in this program with CMS. So happy to answer individual questions on that via the EQIP inbox with Chris. But please let us know if you have specifics there. Next one. Additionally, the care partner arrangement will serve as notice to each participant that we are creating a care redesign program committee. We will work with the CRP entity, University of Maryland Medical Center and University of Maryland Medical Center to maintain this committee that meets all of the requirements of the program. So you as EQIP entities and care partners will not have to set up your own committees. You essentially can clue into our committee that we are setting up at a statewide level. This committee is familiar to others who participate in care redesign programs, but essentially it will provide oversight on the implementation of the program and quality improvement components that we've implemented. It will also provide a forum for us to share ideas and identify problems and develop solutions similar to what we've been doing in this group. It will also offer feedback to our internal program framework as well as the policy year over year. And it will help to monitor participation to ensure that we have compliance with select and requirements of our model with CMS, but then also ensure that we are driving results with this program and driving towards success. So all care partners and EQIP entities in EQIP are invited to listen in to our care redesign program committee meetings, which will we hope effectively for now take place during this subgroup, though we may branch this out into a more advisory body in future months. Next slide. We're almost getting there. I know legal stuff is, very fun on a Friday morning. So thanks for sticking with me. And Erin, I see you have a hand up. Is that,
Yeah, I just have yeah, it is. It is. Thanks, Maddie. I just have a question about the Care Redesign Program Committee. And you might have mentioned this a minute ago and I missed it. Will they only be looking at EQIP or will they be looking at all of the care redesign programs?
Good question. This will be specific to EQIP.
Okay.
Thank you. Yeah. So some final sections here. We will outline the state's reporting requirements to CMS. Within this, we are going to say, we are handling reporting. There's not any direct reporting from care partners or EQIP entities at this time back to CMS. However, to ensure that we can satisfy our obligations to CMS, care partners and their employees may be required to provide data and sufficient access to records upon request. This is not dissimilar from other CMS auditing authorities and privileges. We are not requesting anything at this time, nor have we in the past. This would be something in addition to our regular monitoring requirements should we need them, and we'll fully communicate that and work with participants, but we do want care partners to know that this is a possibility in the future if required. And again, the second bullet here is saying we are going to design everything to intake everything through EQIP. So any additional requests would be ad hoc to that, and everything right now that you're providing via enrollment and ongoing participation through EQIP or that CRIS portal is all that we need to run the program. There's also a section on program integrity, which essentially says if we've found you to be violating any CMS oversight or laws or have significant issues within the program, we may impose a performance improvement plan or corrective action plan for each entity. We will also collectively terminate any care partner arrangement if we determine that you've breached your care partner arrangement or failed to comply with a performance improvement plan or threaten the health and safety of a Medicare beneficiary, or are subject to any other state or federal corrective action. So essentially, you can be removed from the program for bad behavior, and this section outlines kind of the parameters there. Okay, so to get into the process a little bit more, again, anyone who has signed by December 31st will be included in participation year 1 and certification to CMS into the AAPM. We will email the care partner arrangements directly to each care partner to digitally sign with the administrative proxies of each EQIP entity CC'd. This will be the one touch that we have directly with each care partner to sign their arrangements. EQIP entities and their administrative proxies will be able to track which care partners have signed the agreements in EQIP based on reporting. So essentially each week we will go in and batch upload who has signed their care partner arrangements. That will get reported back to you all in EQIP in that care partner dashboard where each of your care partners are listed. So you will be able to see, hey, I've had these doctors signed, I can take them off my list, but I still need to hound X, Y, and Z. So in that way, we're really trying to get that management back into the EQIP entity's hands and ensure that physicians are not getting a lot of random emails from the state or from the University of Maryland Medical Center. All follow-up reminders will flow the EQIP entities via the email system that we've set up. I'll also note that we are going to be archiving each of the emails that we're sending out to EQIP entities and administrative proxies very shortly. So that way there will be a sort of message board where you can go back and see past notices and past outreach to each EQIP entity. So that way, if you miss an email, you can always go back to our message board and kind of check in with the program.
Will the list in EAP have what contact information its stuff is being sent to? So if there's an error or something, they can look at it and see it.
Yes, exactly. So we are using the emails that you all provided in enrollment and can update and clean up right now. So we are only going to be utilizing the information that you all give us to generate and send these care partner arrangements.
Well, my point is when they go in, they can say, oh, we transposed
This
two
email.
letters, and that, yeah, so that kind, I mean, that kind of stuff, that's helpful if we make it easy for everybody. All right.
Yep, exactly. And as well, they are going to be digital signatures, but if there's an issue getting a contract out to care partner, we can work with the EQIP administrative entities to get the contract over to that care partner. So are there questions, concerns, comments on that process? Again, I'm very sympathetic on the individual care partner arrangement process. We at the state are a little nervous about, anticipating and trying to build in resources so that way we can manage a large bulk of contracts coming our way. So we are sympathetic with you, but I think over the next 3 months, we can really get this together if we keep things organized and kind of work together on this.
And I'll just say, MedChi is happy if there's something we can do to help you with getting your practice or your folks to sign up or answering questions. If there's something you think we can do, just reach out and let us know.
Great. Okay, so we will continue on. So just a note on data and analytics. So we've gotten a bunch of really great questions in as people are starting to think through their episode selections. We are working to develop reporting within EAP and inform participants of performance analytics program summaries and opportunity within the program. We plan to include NPI specific views of a couple different key areas. We've gotten some good input on what would be helpful to break down by episode and then within an entity by provider. So we will be providing dashboards on unplanned admissions. So these are admissions after a trigger date or after a discharge from an inpatient service that you will be able to kind of drill down into and understand what is happening there. Place of service, where was the trigger procedure performed? Was it in an inpatient area, outpatient, ISC, and how does that vary across your EQIP entity? Type of service, what spending is within the episode pre and post trigger windows. So where are service dollars going and what is that spend on? Is it on imaging? Is it on PT? Is it on office visits? You'll be able to break down and really understand within each episode where is the spend coming from and what services. And then finally, we will be providing opportunity summaries and complication rates, again, at the EQIP entity level, but then drilling down into a by NPI or care partner specific view. So this will include analyses on avoidable complication spends and types and really where the opportunity is for interventions to impact the cost and quality of care and really succeed in these episodes. We also will be providing detailed claims for download. So you actually as an EQIP entity can download all of your EQIP episodes and see every single claim that is included within each of the episodes. So for the more data minded who want to kind of crawl around the analytics themselves, we will be providing you with those raw extracts. Our expected go live is 3/31 for performance year reporting. We will start to push insights out into the dashboards as they are ready. So we will communicate that with you all. If there are specific things that you're interested in knowing a little bit more about, please reach out and we can see what's available and get that to you. Will sample extracts be available prior to 3/31? So I am not going to commit to anything prior to that 3/31 date. Again, things as they are ready, we will get them out to participants as quickly as possible. I recognize that data is a really big part of managing participation and ensuring that you are successful in the program, though I think at risk of my programmers and wonderful staff at CRISP kind of walking off the job, I don't want to commit to anything earlier than March 31st.
Maddie, just again to clarify, so with the detailed claims, so you're saying that for the MPIs, the individual providers would be able to do a deeper dive and look at actually like an episode per patient. So
Yes, exactly.
Okay.
So you would have everything raw that we do. It's similar, Nikki, to the DEX output that we have for EQIP. If you're familiar with that, but it's similar to that in terms of the detailed level. So it's essentially everything that we would have at the state level, what we'll give to you.
Thanks.
And that 3/31/21 is actually 3/31/22, right?
Yes, thank you. We will not be time traveling. Okay, so now I want to get into another really exciting resource that we have developed at the state. And here I want to give a huge shout out to an intern that we've had at the HSCRC, Lynn Diven, who is here with us from the University of Maryland. And she has really done a huge effort in putting together our EQIP episode playbook, which is a summary of the Prometheus episodes. So that way you have details on how these episodes are created. And then also once they're created, what services and costs are assigned as relevant when the claims come through. So huge shout out to Lynn. I think she's created a 140-page PowerPoint for us on that as a resource, but I think it's going to be a really helpful way to communicate with care partners in the program what's included in the episodes, but then also get people a deeper understanding of how episodes are created and the costs are cataloged. So thank you, Lynn. We've developed performance summaries for all 15 episodes in performance year 1. And what we've developed is a summary over the trigger codes that initiate an episode, the trigger diagnosis codes, which must be on a triggering claim to confirm that the trigger is valid. And then relevant diagnoses claims that flag claims that are relevant to be included in episode costs, relevant procedure claims, same thing, they flag individual claims that are relevant to be included in the episode costs, and then complication codes. So the complications that have been clinically validated by Prometheus to indicate that a complication or potentially avoidable event occurred within an episode. So I'll give you an example utilizing I think our hip fracture episode, or it could be our hip replacement episode, but I'll be posting this episode playbook to our website within the next hour at the HSCRC. So I really do encourage people to go and download what's available and then reach out if you have additional questions. We are happy to provide the individual codes back as well to participants in the program. However, we just figured people did not want to receive an Excel spreadsheet of 30,000 codes for each episode, and summaries would be much more digestible by both EQIP entities and then your care partners as you communicate with them. Though I do want to caveat all of this with the codes are available as well. I'll also add one last caveat before we get into it, which is that you will not be able to recreate the Prometheus episodes utilizing these codes. There is a lot of business logic that lives within the algorithm that we are not privy to, which is a part of the reason that we wanted to go with Prometheus, so that way we could have a larger structure and engine maintaining these episode definitions year over year. These are provided for illustrative purposes only. So please do not come to the state and ask to reconcile, well, we built out these episodes in our data, and this is what we're seeing in the Prometheus output and what's happening. We will not be able to go through that process, nor do I think it will be a good utilization of our time or your time as you're kind of thinking through participation in the program. So without much more, let's go into the first definition. So we are doing, the first one is on hip replacement. We will not go through all 15. I'll just go through this one just to kind of walk through how it works. There will be a little bit of blurb about, kind of what's included in the episode, if it relates back to any other episodes or interacts with other episodes. One that comes to mind is the AMI episode may have procedures underneath it that get pulled in. But just giving you an overview of what's included in the episode and how an episode works at a very high level here. Next slide. So each episode will have a description of the episode length and what the window looks like from trigger to post-discharge and pre-operative care, how long that is and what the windows look like. So when we say the pre-trigger window for hip replacement, we're talking about 30 days. And when we say the post-trigger window for hip replacement, we're talking about 90 days. Just a visual to help, chat providers through each of the episodes as you're working with them on performance improvement. But then also, I think visuals are always helpful in kind of talking through these things. Next slide. Each episode will have a slide on what triggers the episode. So these are the groupings of the different CPT and HCPC codes that will actually initiate an episode. So the claims and services that are going to start an episode for each episode type. So in hip replacement, it's partial hip replacement, partial hip revision, total hip replacement, and resurfacing and revision as well. Next slide. And here's where we get into the summary level, though, again, each of these codes and groupings of codes is available should you want it. So it will go into all of the trigger diagnoses. So we're going to list them here. These are all ICD-10 codes and groupings, but every single diagnosis that would qualify when coupled with one of those trigger codes on the previous slide. So if we see a CPT claim for total hip resurfacing, the algorithm then goes and also looks for a ICD-10 code for one of these triggering diagnoses to confirm that the episode exists. Next slide. Again, getting into more and more detail here, but these are the relevant procedures. So the ICD-10, CPT, and HCPC codes that could tag a claim indicating that a procedure was relevant to the hip replacement. So as you'll see here, it's very expansive. It covers everything from nuclear imaging over to antibiotic treatment, to therapies and different tests and prosthetics and really anything that would be relevant to that hip replacement working. And I will note here, Prometheus and Change Healthcare maintain these definitions. They have a council put together to clinically evaluate any new codes every year. Make sure that things are up to date. So these lists are updating with each version of Prometheus. So we'll keep you all up to date if there are any additions or changes to the episode definitions as we go on. Again, more relevant diagnoses and ICD-10 codes that would tag a claim and include it in the cost for each episode. So each episode description in the playbook will have a couple slides of relevant diagnoses for you to understand and work through. It will also tell you what complications and complication code groupings there are. Again, these are ICD-10 codes indicating a condition is there. But it will help providers to get an idea of what things will be tagged as a complication cost. Not to say that all of these complications are potentially avoidable. It's just going to tag the costs that are from complications care. So for hip fracture, it can be anything from dehydration to MRSA to other skin conditions, shock, cardiac arrest. Pretty typical things that we would consider to be a complication of someone receiving a hip replacement. So again, it says is available, but it will be available within the next hour on our HSCRC webpage. So there will be a set of slides similar to that. So that was the hip replacement episode, but there will be one of those for all 15 episodes that are being brought on in performance year 1. If you have any questions, again, reach out to that CRISP inbox for technical assistance. We are happy to provide the codes back via Excel spreadsheet if that's of interest to you all, but I'm happy to answer any questions and kind of chat through the episode definitions and how they work as well. So I'll I'll just mention that our next subgroup is October 22nd. So it will be after that October 15th deadline or closure in EAP to get your episodes selected, your intervention selected, make sure your care partner lists have correct email addresses. So that way we can start generating care partner arrangements. And in the interim, please let us know if there's anything else that we can be of help with. So I'll pause and see if there are any questions.
I had one person ask a question about, can we do some work around best practices for the quality measures? And I saw we had earlier one in the chat on BMI. I don't see why we can't do that. That's not a bad idea. Maybe we could figure out how to put some brain power to it and put that on a future agenda.
Yeah, absolutely. That's very helpful.
I think that makes sense.
Yep.
And I guess another question I had, and this is because we're obviously looking at results with my physicians in Maryland primary care program. Are we going to have the same type of satisfaction surveys that they're using in the Maryland primary care program for patients in this program as well?
No, so we are not planning any sort of external outreach to patients in the program, and all of the reporting requirements that you see right now within EAP are what is the bulk of what is required throughout the performance year. So no. Yeah,
and it would seem to me that we've got a much better list of requirements on this one than that one. Just saying. That's editorial, not official. Anyway. Any other questions? All right, Maddie, Tequila, anything else that we need? I mean, are we gonna give everybody back almost a whole hour today?
Yeah, I feel like
that's what I aim for. Yeah.
No, I think that wraps it up. We have continued to say that, we are appreciative, obviously, of Jean, your specific help, but MedChi's partnership in general. And so our goal is to continue to be transparent and open as we wrap up the enrollment period for year one and actually then begin to start to look at year two. So we ask that you all continue to be engaged. We get a much stronger product when people provide us with input and ideas. And so we just ask for your continued engagement as we move forward. And so with that, I think, Jean, you're right. We're giving folks an hour back in their day on a Friday.
Well, and again, this is not exclusive, so don't feel like this process. The reason that we've been successful in building this is because we have been collaborative and open. So if anybody has a good idea or suggestion for a meeting or what we want to talk about, we really want to hear it, and we'll get it included. So having said that, unless there's any questions or anything, I just want to say thanks to Madeline and Tequila and everyone else for all their hard work, and have a great weekend.
Take care, everyone.
Thank you, guys.
Thank you.
Great job. Thanks, everybody.